Well, good afternoon and welcome to this webinar with Pro Patria Centre and JointFit Beyond the Clinic. We're delighted to have the team with us this afternoon to take us through this fantastic program app, therapy, holistic care, but we're going to let the team to actually get on the team to actually talk about it. We will have questions at the end, so if you are on live, you'll be able to put a question into the Q&A tab or into the chat, and towards the end of the presentation, we will get to those questions. So to start off with, I'm going to hand over to Courtney from JointFit to introduce the team and to get the session started. So over to you, Courtney.
Yeah, thank you so much, Jackie, and to everyone in the Pro Patria community. It's great to be invited and come along with you today. So my name's Courtney. I'm a registered nurse and also one of the founding team of Beyond the Clinic. Online today, we've got Dr. Jason Song, who's an orthopaedic surgeon and co-founder and medical director for Beyond the Clinic. And we've also got Beth and Jess, who are our lead physiotherapists. So today, we're going to explain to you what JointFit is and really where Beyond the Clinic came from in terms of an idea into fruition and into practice today. We'll talk about some of the clinical integrations of JointFit and how it can be used, and then give you a really good program overview of what's involved in our digital program. Beth and Jess will give you some good patient insights and how we can actually use JointFit in your practice. And then, as Jackie said, we'll have some questions at the end for those of you who'd like to have some more in-depth conversations. So I'll hand over to Jason, who's going to give us a bit of a background of JointFit and Beyond the Clinic.
Thanks, Courtney. So thanks again for this invite, and it's always a pleasure to talk about a topic that's very dear to my heart. Just for way of background, I've been an orthopedic surgeon for over a decade now, sad to say, and I was a Sydney trainee, Northside Sydney, for the orthopedic program, and my fellowship bent has always been around arthroplasty. So I've done training both here and overseas, mainly at hip and knee replacement. And currently I work on the southern border of the Gold Coast, and my catchment area pretty much spans from the Gold Coast and the Northern Rivers community in northern New South Wales. So I get a good feel for both urban as well as regional medicine and orthopedics. So currently, realistically, my 80% of my practice, or probably a bit more like 70% now, is primary diagnosis of osteoarthritis of the knee and then the hip. So my practice pretty much is hip and knee arthritis. My area really is more of a retiree community, so I do less sports and more arthroplasty. So this sort of problem is pretty much part and parcel of my bread and butter work I do in my practice. And as you all know, having dealing in this space for some time, surgeons aren't very complex creatures. We have two levers to pull: non-operative or operative management. And operative really stems either a replacement or something to kick the can down the road and avoid a replacement. And the mainstay of my treatment algorithm when it comes to osteoarthritis establish these functional severity and what is the minimum intervention that we can get to get the desired outcome, which is better function. And it's not always a joint replacement, which is not a surprise to anyone. And sometimes non-operative management is by far the most appropriate means to get the desired outcome. And also, it is also the hardest. So the main issue that I have when we talk about treatment, just the next slide, please, is trying to work out and navigate non-operative pathways. And on the left-hand side of this slide, you see this is what the Excellence Commission in Ministry of Health in New South Wales suggests as how to manage patients for arthritis without surgery. And it looks quite neat and clean and concise. In fact, when you're actually trying to do this in practice, it is none of those things. It is convoluted, difficult, and it's hard to access services in a meaningful way. Patients get lost all the time. In fact, anecdotally for me, it's way harder for me to enable appropriate non-operative management for treatment of osteoarthritis than it is for me to offer someone a knee replacement, which pretty much signals alarm bells when our system really is probably failing patients early disease states when they can't access that service seamlessly in a meaningful way. And so what we're trying to do with this service we're providing with JointFit is an extension of what I did back in the early days at the public hospital work at Twin Hospital, trying to understand and improve the ability for patients to access non-operative management at these phases of arthritis. So we basically tried to enact the OACCP model in New South Wales, and we aptly called it the CAHAS, or knee and hip arthritis service. And what it really does is boil down is how do patients can get some sort of cohesive, consistent messaging, consistent care for osteoarthritis. And unsurprisingly, it works. It's a good service. We were able to make some really important landmarks that are displayed on this slide and avoid knee replacements. And in some patients, their outcomes were so good that they didn't bother to see me anymore for their knees. And so the natural extension of this is to be able to extend this service to the wider community. This particular service that we created through the public hospital was pretty labour intensive and very manually focused. That the infrastructure is not there to scale that really beyond full face-to-face care, which is not something that we can realistically get outside of the public hospital environment, which is a relatively small, siloed environment. And so where JointFit comes in is we have extended that process and tried to bring it to the wider community. And this comes at a great innovation time when innovation and technology is probably something where healthcare can benefit from. And the only way that it can really achieve this in any meaningful way, especially for remote communities or for people who are mobility impaired, is with technology. And so what we've basically done is taking all the services we know works, and we've tried to package it up in a way that's technology enabled and able to create a personalized service by enabling clinicians to remotely provide the same care they would do face-to-face. We're not replacing care with an AI tool or a piece of software. We're enabling care clinicians to provide the same care remotely that they were doing face-to-face. And that's the real difference here. So, and JointFit is really the evolution of that service. So that pretty much talks about the prequel to why we are here today, and hopefully that strikes some chords with some of you listening. And I think I'm now going to hand over to Beth, who's going to take us through the actual program and what's involved.
Alrighty, thank you so much. And it's always good to really hear where we came from, and it's really lovely to be invited on today. So I'm a physio with nearly 20 years experience as a physio, which again is, I shake my head sometimes and think, wow, that I'm very passionate about preventative healthcare, and as having worked in the preventative and musculoskeletal space, but also in the acute post-operative space of physiotherapy with joint replacements, I know how important and how, like Jason said, how hard to deliver really good non-operative care and education to patients that can help them live a really good, high quality of life and mitigate any arthritis early, and then potentially help them make a different choice if joint replacement isn't what they are ready for. So we have lots of different reasons that patients would like to deal with their osteoarthritis preventatively. Sometimes people want to work longer, spend time with their grandchildren in a different way, maintain their levels of activity. And that's where JointFit can come in to really give patients a consistent opportunity to learn and to better their own well-being through personalized physio programs that we deliver to patients' phones. So the goal for us is really to deliver education, first off, accountability, and then strength and balance improvements through our app in order to really strengthen, stabilize, and help patients for wherever they're at on the osteoarthritis journey. So whether patients are trending towards surgery, or if they're really just at that point where they're starting to think, oh, my hip or knee is really starting to change my quality of life, what could I do differently? So I'll let Jess introduce herself. She's worked more across the post-operative space as well. So I'll let her chat to her own experience and role within JointFit as well, beyond the clinic. So what we are physiotherapists who deliver this program, and we run consults using telehealth through the app that Beyond the Clinic has developed. And so we very much run a personalized service, and we use technology to deliver our assessments. And we use video technology as well to help patients understand their exercise programs. We can assist them to know that we're doing them correctly. One thing COVID really showed us is we can't just expect patients to do what we say without really knowing what it is they need to do. And that's where our technology can be super helpful. So we've got the app with our personalized motion tracked workouts, and that also allows us to have visual measures on things like range of movement, and helps patients to complete their assessments. I'm just trying to get my slides to move across. Just a second. Jess, would you like to just quickly speak to your experience with how patients have been finding what we're delivering?
Sure, thanks, Beth. Yeah, as Beth said, I'm also a physiotherapist with mainly quite a lot of experience in musculoskeletal and orthopedic patients, both conservative, managed, and post-op. And I find, as Jason said, we're not removing the role of the therapist, but we find this JointFit has been a really, really good adjunct to the traditional therapy. So we know there's not enough therapists, clinicians to be seeing these people as often as they need to be seen. So the app has really provided a really good education for these patients first up, so they do start to become better self-managers. And I think that's a really important part of what we're trying to do here. We're trying to really get the patient to take control of their own care as well, whether they're managing it conservatively or going through and having surgery. And then secondly to that, it allows us as clinicians to set them, whether it's exercises or give them education, but then let them go away and work on those things in their own time and at their own pace, and as they feel comfortable in their own home. And we don't need to be getting them into the clinic every week to check on them, because we're able to do that remotely. We're able to see if they're doing their exercises. We're able to track, okay, what's your pain like? So therefore we can push those appointments out a little bit more, but still know that those in between those appointments, those patients are still getting what they need to do to keep progressing along whatever path they're choosing.
One of the key things as well, we're finding, it's probably not captured quite on one of these slides, but that mindset when it comes to managing chronic or long-term pain or slow decline, mindset is a huge thing that, can be a bit of a barrier to whether people access services ongoing. And finding that being able to deliver healthcare within a patient's own home, in their own time and in their own environment is and with the accountability, excuse, there's a plane going over, with the accountability factor of having the reminders coming through the app, having the ability to build consistent healthcare habits at home, and things, within the app that really help people to re-engage with their health and rethink on a daily basis, I could do this, I need to do this, and working through the timelines, particularly when they are on a longer term program with us, giving them those kind of touch points and assessment points that really help them to say, actually I have done more this week, or I am able to do more. One of my patients today who's only been on the program a couple of weeks commented today, I've actually noticed I've been doing the stairs without using my hands the last couple of days. So those are the small little changes that, particularly people with osteoarthritis who've gotten used to maybe doing less, are observing through our program. Alrighty.
So Beth, are you able to just talk through exactly in terms of the virtual physiotherapy, how that works in terms of the individual exercise prescription for patients, and then also how they're able to do that without wearables and at home as well.
Yeah, absolutely. So just like any initial consult with a patient, we do a face-to-face video call with the patient. And before they do that, or after sometimes, depending on how the flow goes with patients, they do get sent a pretty straightforward set of assessments that we can pair up with what they have as a, initial consult. So once we've gone through that and take medical history and all those other key parts of the assessment, we then prescribe them an exercise program. Now, we start off very moderately, and the aim is really just to build confidence and strength at the beginning, but in a very measured and controlled way. We prescribe an exercise program that comes out to the patient's app. They're able to see it through a little video. There's a little video person that shows them how to do the exercises, and they're able to set up their phone or device so that the camera is able to see the patient. We can't see the patient. All we can see is whether they did it or not, and how well, like, the app is able to assess the range of movement and how well they performed the movement, how accurate to the exercise the patient was able to do it. And they are able to follow along with their home program. So what it does is it gives us really nice two-way communication about how the patient's managing, and also whether we need to make it harder or easier. And obviously, if there's something that they're not able to do well, we can change the program. So it gives us that really nice, relatively real-time feedback about how a patient's going. And also they've got the access through the app to actually message us and give us feedback as well if something wasn't working. So then we have, inconsequential appointments. Those, especially on our longer programs, those exercise programs are ramped up in accordance with what the patient's functional goals are. And so those physiotherapy touch points are really vital to making sure that those home programs meet the patient where they're at and work from there. So there's also, within that, there are touch points that give feedback in relation to assessments that can go straight back to the patient's referrer. So if say Jason was to refer, Dr. Song was to refer a patient onto our program, as we go along at predetermined touch points, that patient will be reassessed across a variety of areas, and that feedback will go into a report that can go back to the clinician. So it just is a nice umbrella way to make sure we are providing a real collaborative care model that keeps the providers and the referrers in the loop with where the patient's at.
Yeah, great. So Jason, are you able to just give us some insights into the reporting that we're giving back to clinicians, but also to patients with their progress as well, in terms of the assessments that we're collecting from patients, their workout adherence, and also that risk mitigation area as well?
So this is what I think one of the big values of what we offer is we provide good snapshots into what the function is. So the most important thing is a good assessment returned from the physiotherapist who's treating the patient to give you a summary of exactly how they've been going, which probably gives a good snapshot of how they're tracking. What we typically check is a standard PROMS score, which is an objective measure of patient-reported outcome measures for living with knee osteoarthritis. So it gives a good functional trending line between what their initial scores and how they're tracking at the completion and during the middle of the program. It also measures how often they're interacting with the software, and gives us information in regards to the other measures, such as what's called the Promise 29, which is a good snapshot of their non-orthopedic functions of daily life and how the overall quality of life measures are tracking as well. So for me, what I like about it is I can open up a patient's file when they come to see me for a review appointment. I get a really good snapshot in time about what they've been doing in the last 6 weeks, 3 months, how they're tracking, and it's usually on one page, and I can consume the information in less than 10 seconds, and then I'm up to date. So immediately I know I can pick up a patient very well is the program. They've already walked in the room. I've already know what I'm going to say to them because I basically don't need to be there anymore. I probably won't see them for a year. And that's so for me, it improves my efficiency, and I get really good feedback. Probably as a side point, I know you didn't specifically ask me this, that probably my biggest bugbear I have is that when I send patients for non-operative management, there is a 9 in 10 chance I get zero objective feedback from who I'm referring to about how they're actually doing. I usually get no information. So then I'm trying to extract that from the patient, which is a really poor way to get the information in a meaningful manner.
Yeah, great. Now we'll just talk about some of the benefits, and maybe, Jess, if you want to just explain one of the, success stories that we've had with one of our patients, and Beth, then if you can just talk to some of the benefits.
Yeah, sure. So as we were saying before, I think one of the biggest benefits out of this program is the amount of education that each patient receives. Through the app, there's, depending on what pathway they're going through, so whether they're having surgery or having conservative management, there's obviously different education cards that they receive, and they receive these slowly over time so they can consume the information at their own pace as they're ready. But we have found that the more education we give these patients on their condition, the better they have become at understanding why we're asking them to do what we're asking them to do. And therefore, we're getting a lot more buy-in to these programs rather than just seeing someone throwing a ton of exercises at them and saying, like, we'll see you in a fortnight. If we can continue to educate these patients, we can continue to help them become good self-managers, which I think is a big part of what we're trying to do here, so that these patients aren't relying on appointment after appointment, someone else telling them what to do week after week after week. And then so within that, we're able to hopefully get them to, manage their pain better. We're not going to get rid of, all their pain. That's not what we're trying to do here. We all know that that's, particularly for those conservative management patients, we're not probably going to be able to do that. But if we can help them find ways to better manage their pain, so therefore they can improve their function and their quality of life, that can hopefully help move them forward along their pathway as well. And then through that, with this, long-term education and helping them become, better self-managers and finding the things that can help them, they can make a really informed decision on whether they think the surgery is the right thing for them, and they can go back to their surgeon or their specialist and have those conversations as someone who has been really well informed and really well educated and isn't just there because they don't know what else to do or where else to go. We had a 55-year-old patient come through our program through the education and giving them a regular exercise program to complete. We were able to get to a point where we didn't totally put surgery off altogether, but we're able to delay surgery, which is really important for especially a 55-year-old. They have a lot of life to live and they have a lot of things they're still trying to do. They're trying to work and things. So even if we can just get them to delay surgery for get a few more years, get their pain under control, and we all know that if the more mobile and functional we can keep someone, if they do choose to have that surgery, we know that's also associated with better outcomes as well. Also with the app, as Jason was saying, we're able to monitor these patients quite, a lot more closely. We can see, if they're doing their exercises. We've all had those patients that you send away with exercises, they come back, they say they've done them and they obviously haven't. So we actually can see, have you done your exercises or not? But also, are you doing them properly? We've also all had the patient that you give them squats, they come back 2 weeks later and they're standing on one leg, turning around in a circle, just not doing anything you ask them to do. So therefore we can say, okay, well, you're doing all the right things, okay? Do we need to change something up? How else can we help you? But also it means that there's a lot of that accountability, again, goes back onto the patient. If you're not willing to put in then, there's only so much we're going to be able to do to help you. And then through that, we can get these really, really great reports that are really in depth, but very easily displayed in graphs that we can really easily see how is this patient been trending. And that can very easily go straight back to the specialist when the patient is back there and they're considering what their next steps are.
Thanks, Jess. So I think it's always important to explain what we are and what we aren't in terms of a program offering. So we like to think that we are an extension of a clinic's care, hence the name Beyond the Clinic as well. And as Jason and our team have explained today, it's really looking at that clinical efficiency and how can we better use our clinicians to scale as well. We all know that there's a clinician shortage in any allied health or any clinical area at the moment, and that's only going to get worse. So other things, we're building this to be API first for integration. So in terms of when we're thinking about software and also moving forward with technologies, we've put that in the forefront in terms of integrating with practice management softwares and things down the track. So in terms of what we're not an electronic health record, so we're not storing patients' health data, and we don't rely on any wearable data as well. So the technology within the app, it's no one needs to wear a wearable, they just need a mobile device, which we've all got them, it's amazing. We've all travelled to different parts of the world and seen how no matter where we are, someone has a mobile phone. So, and it's an interactive. And one thing that we kind of spoke around was this hybrid model of care that we're offering as well. So that's really important that, COVID made us realise that we can consume healthcare differently, and how important technology is going to be to provide healthcare services to the greater population. But we're still healthcare professionals, so that having that hybrid model where people know there's humans behind the technology and we're an enabling technology, that's really key to what the service we're trying to provide. So that's just a few points there to enforce as well. So yeah, I'll invite Jackie back in, who has got some questions for us from the panel, and then also there's a QR code there that you can go to our website and find out more information. And also, if you'd like to get in touch with us, you can do it via our website.
Fantastic. Thanks, Courtney, and thanks everyone. That was a very informative presentation. We do have some questions, so I'm not sure who the best person to answer some of these things are. So I'll ask, and then you leap in if it looks like you.
So our buzzers ready.
The first one that's come up is, how much additional time will it take for my clinic staff to onboard?
Yeah, I might jump in and answer that one, Jackie. So at the moment, especially with our offering, we're trying to simplify that process. So really trying to reduce the workload. We know how busy clinicians are. So what we're asking is people to head to the website, and if they have a patient who is interested in it or who they would like to refer, they can simply do it through our referral forms online. From there, our JointFit team will be in touch and be able to support the patient into what program best suits them.
Terrific. I can tell you it's easy. I've signed up, so I'm a patient. It was pretty simple. Okay. How does the platform integrate with a clinic's PMS?
Well, as I said, at the moment, we're building it so it is what they call API first, and that means that it can integrate with other software systems. And we can see the future is that. So at the moment, we don't currently integrate into any PMS, but we're building it so that in the future that will be an option for potential partners and opportunities.
Okay. And now we've got, what's the process? So if we've got a patient who's got escalating concerns, how does that escalate through the system if they're identified?
I'll let one of our physios answer that.
I'm going to assume that we're meaning this like as a patient whose symptoms are getting worse and they're already on our patient load. So we have a pretty stringent clinical risk escalation process. where we circle back to the referral or the GP, and we have our internal risk management system and clinical risk assessment, where they'll be, followed up by the physio closely, and then referred on depending on what's required. Obviously changing in their program or changing in their management plan would be appropriate if necessary. And then we do have, an escalation tool that helps us to make good decisions around which, who the referrer, or if it's a medical, some patients will come see us for a knee and then they have something else happen. So we as physios and clinicians in general, we will, refer back to the appropriate medical professional. And obviously there's always the assessment of whether someone's needing emergency care, where they would be prompted to access that, or that would be escalated as well from our end in that situation. But those things are, for the most part, we end up managing within a fairly, tight sort of boundaries, and we know where our clinical management sits, and we have escalation tools for anything that sits outside of that. And remote care, you have to be very, very aware of that, because we are not face to face in that setting. So yeah, we've put a lot of thought and effort into that as we've worked through that with our patients, evolving our tools.
Terrific, thank you. So we're reasonably tech savvy here. but what happens? How are we managing patients who aren't all that tech savvy, or perhaps don't have access to a smartphone?
Did you?
Yeah, absolutely. And I think it's important to realize that our program might not suit everybody, and that's okay. There's going to be some people out there that might still have a Nokia, I don't know, built in the 19 whatever, and that's okay. The access is important, and that's one of our patient criteria that we go through in that first initial concierge phase of onboarding a patient. So obviously we'll need to gain patient consent, but we also take them through several steps to ask them about their digital literacy and capabilities as well. But what we like to say to our patients is that if you can FaceTime your friends or your grandkids, and you can send and receive a text message, then we'll be able to support you on this device as well. And I think that's changing in our population. I know that my mum, who's in her mid-70s, can drive Facebook like no one else, and they're pretty tech savvy out there in that age group as well. They're pretty well connected.
Terrific. Yeah, I think the Nokias are making a comeback. Some of them.
True.
They're calling them dumb phones or something now. Yeah. Okay, so how are the exercise programs personalised for each patient's specific condition and capabilities? Don't rush me. Who's that one?
You can speak to that one if you like, Jess. I feel like I've talked a lot.
So as Beth was saying, we always do an initial consult, same as you would do in a face-to-face clinic. Ours is just via telehealth. We also have the patients fill out all those questionnaires to begin with, so we can gather information from that as well. And then we have a whole library of exercises we can pick and choose from. So as clinicians, we're, picking the exercises we think are most appropriate, and also, those are controlled with sets and reps and how many days a week. So we can prescribe all of those parameters as well. And that's obviously based on what we find in our assessments. But then also with the technology, because it's tracking those patients, we're able to see, are they doing it? Are they getting through them? We might have given them 10, but we can see every time they're doing it, they're stopping it at 8. So we, can touch base with them and say, hey, is this too much? Are you finding it difficult to get this done? Is it giving you any more pain with the exercise as well? So yeah, we can really kind of hone in, and we don't just have to wait till the next time we have an appointment with them to ask them, how have you been doing your exercises and how have they been going? And then from there, we just make our appropriate changes to exercise programs as needed.
Terrific, thank you. Now, here's one. I'm hoping you know what the acronym is. So what clinical outcome measures and PROMs, PROMS, are tracked through the platform. I'm an economist. I have a whole set of other acronyms. I don't know what that one is. So away you go.
Yeah, I'm sure that's going to come my way. So, so what we have ability to track is the Oxford knee score and the knee osteoarthritis outcome score as our two standard measures for knee osteoarthritis. So they're both got well-validated tools in the literature. When we're talking about hips, I'm not sure if we're allowed to, but if we are, then it's the Oxford hip score and the hip osteoarthritis outcome score. It's the JR version, not the 6,000 question scientific one. So don't worry, it's just usually I think it's a 10 question version for those. So they're more for clinical use. So they're the ones that we use. We add into that BMI calculation, and basically we use a tool called Promise 29, which is very similar to like the Euroqual or those quality measures which are standardized across a lot of different patient subsets with chronic disease problems. The reason we've picked Promise 29 is purely because it's a validated tool that's been accepted in New South Wales Ministry for Health. So we thought for future alignment, that's as good as measure any. However, they're pretty much interchangeable for those quality assurance tools for patient-reported outcomes.
Thank you. I'm sure the doctors all got that. I'm a data person, so that sounds very, very comprehensive. So how accurate is the motion tracking technology in assessing patient form and progress? And can I add another bit to that? How do they need to set up their phones or to be able to track themselves accurately?
I might answer at least the first part of this. So it was painfully annoying in trying to understand how motion tracking and vision-based technology would get range of motion, right? So the biggest worry that I've always had is this accurate? So there's a lot of tools out there now starting to use this as a baseline, and the short answer is it's exceptionally accurate. What it does is it doesn't require any third-party software because the heuristic modeling running in the background can work out via the position of the patient and the movement characteristics when they're performing the movement in question of working out the center of rotation of each joint, and then it creates basically straight lines from the center of rotation from, say, your hip, knee, ankle to get your AHKA, which is your standard form for your knee range of motion in both planes. And it does that for all the joints. When you compare that to a standard goniometer, it's within the same error margin that we accept for any measurement tool when we're taking diagnostic measurements. And in fact, it's got better inter-observer reliability than two trained and double-blinded investigators performing a standard goniometer measurement for a knee range. So it's actually better, which makes sense because it's not as easy as you think just to get a goniometer on someone's knee and get it accurately. So the short answer is it's validated and it's better, and that's how they get the data. And all the movement tools pretty much do it the same way. I've now forgotten the second part of your question, but I thought I was going to handball that anyway.
I think you were anyway. So it's how do people set up their phone or an iPad? Could it work?
Yeah, absolutely.
Do they set that up?
Yeah, and to second what Jason said, this is as good as any hand measurer. Just to give you layman's terms, a hand measurer that physios use or orthopedic surgeons use. So it's pretty good. So you will be instructed to set up your phone on a chair. So it's just literally like a kitchen chair. And you kind of position it so that it can see you, and it will give you verbal prompts as to whether or not you're in the screen. So you might be told to move back a bit or whatever, and then once you are in the screen and you are captured, and you'll be able to see like a sort of a stick figure person that has those lines that Jason was talking about. You'll be able to see that, and then it will be able to capture your movement. So you verbally prompts you and will tell you when you're not in the screen, and then you'll move around until you are.
I can't tell you how relieved I am to hear that, because that's me probably tomorrow.
And
So-
Jackie, it's quite similar to, when you go through the airport and they need to do the face scan and it says stand back, stand forward, look up, look down, and it's prompting you the whole time, and it won't actually capture you until you're in that right place. So.
in the sweet spot. Okay,
Yeah.
that's good to know. Good to know. Okay, here's one about privacy. So I don't know who's putting their hand up for this one. Where is the patient data stored, and does it comply with healthcare privacy regulations?
Yeah, absolutely. So all our patient data is de-identified and it's stored onshore in Australia. And yes, it complies with all regulatory requirements, including cybersecurity, and also moving towards, as a company, moving towards TGA approval as well. So at the moment, clinicians are still making the clinical decisions. We're just enabling them with this technology. So we sit there, but yeah, that's on our roadmap. But at the moment, that's where we're sitting in terms of regulatory compliance.
Okay. So it's all kept here. So that's the good news. Okay. Technical support. So what if there's a help for patients and clinicians? Where's the big help button? How do they get the help?
Yeah, absolutely. So within the app, that's what we were talking about being a two-way communication. So patients are able to communicate with us and we're able to send them messages as well. So as we see the patient progressing, we know where they should be in terms of milestones and assessment cycles, and we can support and monitor them then. If they've got technical difficulties, it's, all our contact details are there either through the app or directly to our support services.
Okay, wonderful. All right, so now we're getting on to a bit of cost, the cost of this. You didn't really talk about a pilot tonight, but we're keen to sort of hear a bit more if you're able to. So what costs are involved in being involved either individually or as part of a pilot?
Yeah, absolutely. So obviously this opportunity with Pro Patria has come through, defence connections with Jackie and myself. And, we see that there's a real need for the defence community, but also the regional community around Pro Patria. So the program at the moment that we're offering is a heavily discounted at $149 to support patients to come in, align their care with a clinician in the area or one of the Pro Patria allied health community or one of the physicians there. And then they will receive their first initial telehealth appointment with our clinicians and then also their program for the next 12 months. Any subsequent telehealth appointments will be charged at a fee and will be rebatable through usual channels. So we're really looking for, the early adopters who see the benefit in this and trying to support patients that live regionally, but also not have difficulty getting access to care, but then also from a clinician point of view, able to look after as many patients as possible to support and monitor them in their joint health journey.
Right. So diggers, you've all got dodgy joints. So I don't think I know anyone that has served in the ADF that doesn't have a dodgy ankle, a dodgy knee, or a dodgy hip, or a back. So it's a good opportunity. We'll certainly be rolling out more information, I think, to individuals as well, so that they can take this to their GP and their physios. I might just leave there were a couple of questions about the volume number of people that we would require for that pilot. That's not really all that relevant, but if a clinic is actually sending people, what hardware is there any additional hardware requirements that they need to have in place?
No, not at all. So as I said, they'll be able to direct patients to the website to put in a self-referral, or as a clinician, if they would like to refer a patient, they can do it through a clinician referral form online there. So, and to start with, those reports that Jason was talking about, we'll provide a PDF copy of those back to the aligned clinician. In time, our technology and what we're building is the ability to be able to have in-clinic portals for certain physios and and physicians if and when they require that. But just to start off, the process will be a self-referral or a clinic referral through the website. So no additional software required, and they can easily just open Google or Safari or their best website.
Okay. Awesome. Okay. Now you did talk a little bit about some of the evidence that supports the effectiveness of the model that you were talking about. Is there any chance you could just maybe point to a few more details on that evidence of that hybrid care model?
So you're talking about the evidence for OACCP model. So
the effectiveness of the model. Yeah.
So maybe Courtney, probably the best thing can you flip back to that slide? That's probably a really good summary slide rather than bore you with a journal article. So when we trialed this, and this is essentially the building blocks for our current architecture. So this is what we did with the caveat here. Obviously, this is a public hospital trial with over about I think it was about a 12-month period with 131 participants who are all patients either referred by local GPs in the in their network, their PHN, or by orthopedic surgeons who worked in the department at the hospitals. That was a group of 7 of us. So there was probably about, in context, probably about a 70-30 split GP to specialist referrals for these. And these are all patient. The criteria was grade 2 to 4 OA of the knee, which was symptomatic. So they hadn't had X-ray evidence of OA of the knee before they could be referred. You didn't see trochanteric bursitis or any other non-joint related symptoms per se. This is specific to arthritis. So the period they reviewed was over 3 months in total, and they did basically the paperwork they did prior was essentially what we talked about in JointFit. There's no real differences there, and then we measured their responses as well as their participation. And basically, one of the good questions I had at the end was, at the end of these was, is your knee better? Do you want a knee replacement? So that's a really good benchmark as well, because it's simple. Everyone has an answer to that, and it's a very binary question, yes, no. So what we found was, out of the people that participated in this program, these were all public patients in the network. 7 out of 10 patients had statistically significant improvement in the Oxford knee score, and with a VAS score reduced. So that was a patient-reported outcome score. At least 2 out of 3 of them within 3 months had less pain. And as you'd expect, they basically were able to walk further, and they had generally had less functional disability from their joint. And the important thing, which one is the LHD got really excited about, 4 out of 5 didn't want to go ahead with surgery, and 78% had an improvement in their day-to-day activities, and that was definitely my experience. So me as a referrer, and my flow was what I would typically do, because they would maybe wait 3 to 4 months for they could get to see me. After being referred, I would typically refer them to the service first after reviewing the x-rays to make sure it was appropriate. And then so they would do that prior to the specialist review. I honestly had about 50% of patients who said they didn't need to see me anymore and never turned up. So, which is all anecdotal as well, a higher no-show rate than what I normally would get for this problem too. So not everyone shows up in all of that, but it was definitely a lot more that actively said they didn't need it because of this service. Because of this, we actually got the Health Minister's Award for Clinical Excellence, and I got the luxury of presenting these findings to all the LHD CEOs in Sydney, which is a very odd experience, and it's got rolled over across New South Wales as a response. So that is the like my own personal experience with the evidence for this particular program.
Fantastic, thank you so much. All right, so here's the money question. Have you got data on patient adherence and outcomes using the platform? Do they stick at it?
Yeah, we really see that behavioural change between 8 to 12 weeks, Jackie. So like anything, we want them to do a bit more movement, obviously some education around diet and lifestyle as well, but it's really having that behavioural change, and our physios can talk to this a little bit more, but having those little daily changes of 2 or 3 exercises like brushing your teeth actually lead to higher adherence rates, and also hopefully seeing those functional changes as well. So currently, we've been running the program with a 12-month leadway. There's a real good engagement of up and reflecting on this study up to about improvement of 70% of function and also decreased pain score as well. And then the 10% rate coming off hip or knee waitlist or deferring surgery is relevant as well. So that's translatable from the bricks and mortar study that Jason did, and then how we've converted that into digital. So yeah, we're seeing the same trends.
Okay, well, I think we've answered just about everything. Have anyone got any last comments or points that you'd like to emphasize?
No, I think we're all good. I think we're excited about the opportunity to support the region as well. So
wonderful. Thanks so much, everyone. It's been really informative for me also, not just as obviously as a board member of Pro Patria Centre, but also as now a client, a patient who's accessing the program. This has been really, really informative for me as well. So applaud you on what you're doing. We're going to get this out to as many people as we possibly can, and we're just delighted to see that there's opportunities to have people in regional areas and particularly remote places too to get access to these amazing programs and improve their life outcomes. So good on you. Congratulations what you're doing, and thank you so much for this evening. Really appreciate your time.
Thanks, Jackie.
thank you.
Thanks very much.
Welcome.